points that we discussed, that is titubation, trunkal ataxia, and impairment in the tandem gait or a gait ataxia, all these are features of very important vermis lesions. So it is a vermis lesion that causes titubation. It is a vermis lesion that causes trunkal ataxia. It is a vermis lesion that causes gait ataxia, and also it can cause, tandem gait impairment. But I just wrote there tandem gait impairment because I wanted you to remember the 3 T's. Okay, 3 T's. Okay, right. So I hope that is clear for you. Now, one additional clinical point. Suppose the patient is having gait ataxia. Okay, gait ataxia, which I told you can happen with vermis lesions. But along with that, he is also having vertigo and vomiting. Then what? Does the site of lesion change? There is a slight change. Vermis lesions are usually not commonly associated with vertigo and vomiting. So this combination of gait ataxia with vertigo and vomiting, where does it happen? Remember, I told you the flocculonodular lobe is also important for balance. So in flocculonodular lobe lesions, you can have gait ataxia with vertigo and vomiting. Okay, so that's a site of lesion in such a clinical context. Moving to the next set of clinical features, most of which are due to lesions affecting the cerebellar hemispheres. Okay, now whatever we are going to discuss are mainly features of hemispheric lesions. Okay, now see limb ataxia. Okay, the next feature is limb ataxia. So limb ataxia is also called appendicular ataxia. Okay, limb ataxia or appendicular ataxia. Now this is different from gait ataxia. Okay, so limb ataxia, how will the patient manifest? The patient will be having difficulty in carrying out tasks that require precision. Okay, for example, buttoning and unbuttoning of shirt, taking a glass of water to the mouth, opening the cap of a bottle. Though there is no motor deficit here, we know that to fine-tune such skilled movements and to properly plan such skilled movements, you will require the support of the cerebellar hemispheres, and here you can have limb ataxia. Okay, right. Moving to the next feature, it is speech. So can cerebellar lesions cause any sort of speech affection? Answer is yes. It can cause dysarthria. The reason for the dysarthria is the incoordination of the various muscles of phonation, like the laryngeal muscles, lingual and palatal muscles, which will cause the speech to be slow, slurred and irregular. In addition to that, there are 2 other specific type of speech abnormalities in the context of cerebellar lesion. One is called staccato speech, the other is called scanning speech. So staccato speech means it is a type of speech where there is undue stress on syllables. Undue stress on syllables. Okay, there is undue stress on syllables, certain syllables. Undue stress on certain syllables. Okay, for example, if I say, my name is Rahul. Okay, this is normal. But if I say, my name is Rahul. My name is Rahul. So, nay. So, there is an undue stress on a certain syllable. This is called staccato speech. There will be an explosive quality in certain syllables. Okay, now this is typically seen in case of Friedreich's ataxia. The classical description can be seen in certain other conditions as well. Scanning speech means there is an undue separation of syllables. Okay, it's not undue stress here, it is undue separation, which means the same sentence that I told you a while back, instead of my name is Rahul, the patient would say, my name is Rahul. There will be a scanning type of speech. Okay, and this is typically described in case of multiple sclerosis. Will all patients with a lesion involving the cerebellar hemispheres will have speech affection? No, it's not that everybody will have. Now, to be more specific, the speech affection is usually the para-vermis or the intermediate zone or the medial cerebellar hemisphere. Again, to be more specific, it is the rostral para-vermian zone. Rostral para-vermian zone. Rostral para-vermian zone. Okay, that is a site that is affected. Okay, right. Okay, that is clear. Next, coming to the next clinical feature. So it is called hypotonia. So hypotonia, what is the reason for hypotonia in case of cerebellar dysfunction? This is due to an indirect effect on gamma motor neuron. So you must understand that there is no direct connection between cerebellum and lower motor neurons. So it is an indirect modulation. So what happens is, in case of cerebellar dysfunction, there is a decrease in the tonic output of the cerebellar nuclei, which will cause a loss of the cerebellar facilitation to the motor cortex, and that is what causes the hypotonia. Okay, please understand the reason. And this will have the effect on which motor neuron? Mainly the gamma motor neuron. In a cerebellar dysfunction, there will be inhibition of the gamma motor neuron, and this inhibition of the gamma motor neuron, which happens indirectly, is responsible for the hypotonia. Clear? Okay.